you will note that the extraction for DNA for this particular technology is separate from testing. So you do, first of all, extract the DNA, and then you move ahead to do the testing. So that creates another difference, and it makes the reagents even to really be very stable. Connectivity solutions are very critical, and this instrument has been wired in a manner that you can be able to connect and have the patients, have the clinicians receive results online. I talked about battery powered, and then the fact that it will be able to help in terms of active case finding. So the steps in terms of implementation, there was a secretariat that was developed in 2021 to support this particular process, bringing all the stakeholders together to look at what we need, the Gantt chart, coordination mechanism by the National TB Program, just trying to acknowledge some of the colleagues who are supportive in that particular process. This is the launch of this particular project by the high-level ministry officials. Then when we look at some of the steps in terms of, we needed to identify which candidate facilities that these machines should be taken to. So there is something referred to as spatial analysis or diagnostic network optimization, if you will, that ensures that we pick a lot of information and put it in a software for analysis. So this process was supported through the IDDS, infectious disease detection process. And we were able to give all the data that was required. And these are some of the results. Well, when you look at the population to be served, because there was the inclusion criteria, the population to be served, we had to give that particular information because it's useful so that we ensure the aspect of equity when the instruments are being distributed. Then the other thing is about the number of other health facilities the candidate facility can support. In Kenya, we use the hub and spoke model, where one facility is given a machine and networking done around those particular facilities. The inclusion criteria, again, here we also looked at the demand for testing in the area based on the notification for the period 2019-2020. And then we also ensured that the preference for the counties as the key stakeholders are also taken in. So based on what I've shared, the prioritization of the candidate facilities, we had around 14,000 that we analyzed, with 146 being eligible, 80 facilities being picked in readiness for assessment, and 60 being ready, 20 not ready. And we went ahead to prioritize that 8 because we needed to make sure that we pick the right facilities that would benefit. These are just about some of the photos with regards to the methodology on how we went ahead to do the assessment using the Global Laboratory Initiative Stop TB tool to guide that particular process, looking at quite a number of aspects on quality management, the commodity management, data reporting systems, and safety and such kind of things. So then after the placement of those, installation of those machines, this is how the country looked like. You can see, where we are having the blue, that's where we have the gene expert, and the red coded, that's basically where we have the TrueNut instruments, and you can also appreciate the establishment of the other diagnostic instruments that we have in the country. Then we went ahead to do cascaded trainings, starting with the managers at the national program all the way to the end user. So basically, this was a training that was done and being opened by the head of program in Nakuru. Number 2, we also ensured that the county teams are trained, because for buy-in, so that they can be able to appreciate this particular technology. Then we went ahead to do the super user. Super user is a medical lab technology who has been trained, has been given additional training with regard to this particular instrument. So we trained around that 3 of them, and focusing on issues to do with monitoring the instrument, mentoring other facilities, troubleshooting issues to do with connectivity, and such kind of things. The other thing was now the end users, the guys who are going to use that particular test. So we trained around 76 of them. If you look at the number of facilities I mentioned, we had 38, so 2 staff per facility. And then the other thing was now the installation of the machines that was done collaboratively with the in-country engine for Molbio. Molbio is the manufacturer of this particular instrument and is Indian-based technology. For the first mentorship that we did, we were able to pick a few user feedbacks. This is usually very important with regards to the rollout of new technologies. First, number one is to note that there was ownership of the instrument by facilities. And then once the instruments were installed in those facilities, there is what you refer to as the lab clinical interface needed to change, because initially they were sending their samples to higher level facilities for testing, and these had already been implemented. In terms of the positive results and linking of those patients to TB clinic for treatment, this was happening. Number 4 was the issue of ensuring quality in terms of testing by supporting the facilities with provisions tests, or EQA, if you will. And then we also noted that there was partner support and willingness to support those facilities to implement. And the other one on issues to do with documentation tools, where the registers and the lab request forms were available for use by the clinicians to request the test. Overall turnaround time was around 24 to 48 hours, especially for those facilities that were sending samples. Super user support, again, I talked about this, which has been happening on a monthly basis, just to make sure that those facilities, they are followed through in terms of the gaps and challenges they have and supported immediately. Then we went ahead to do some refresher trainings, because we noted after the first implementation, there were gaps that were being reported by these lab staff, and we went ahead to ensure that they are trained and supported. I talked about PT implementation. This is through the National TB Reference Lab, which was another stakeholder that was very crucial in this particular process. And these were the steps that we went ahead to implement this process, ensuring that we had all the facilities enrolled, tracking of PT happening, monitoring the feedback, and ensuring that the performance through the Smart Spot company in South Africa is done, and corrective action, preventive actions are done. These are some of the results for the first and second round. Just to note, we were able to have stakeholder discussions about the feedbacks, just to ensure that all the areas that were unacceptable, as you can see, were addressed. And I think currently, looking at the performance, a lot of improvement has been noted. Data reporting systems, we use a system called TBLIMS to ensure that all the samples that are being tested, they can be transmitted online, and the clinician in whichever facility he is able to get an SMS and an email for use. So very quickly looking at the results. So up to March, we have tested around 27,000 people with around 2,683, positivity of around 9.9%. And this is data from that 7 facilities. You will realize that if we did not have these technologies, these 2,600 people would not have been tested and put on treatment. And this is the reason why we are saying, I think at the end of this presentation, I need to convert all of you to be TB champions, ensuring that everyone is screened, even within our institutions. And if they are screened positive, then they are referred for molecular diagnostic testing. This is for you to appreciate the tuna testing trends. We were on an upward trajectory up to around November. We know in December people go on Christmas mood and the numbers go down. But we have really been able to push a lot, and you can see where we are at the month of March. We cannot fail to look at the rifampicin resistant cases, because Kenya is a high burden country for for drug resistance. Been dropped recently, but we still have that particular issue that I think needs to also be focused. So you can see around 56 RR cases that have been reported and put on treatment. So when you look at the pre and post implementation comparison, it's important to note that the proportion of the new and relapsed TB cases tested with at least a molecular diagnostic test improved, approximately around 20%, and also the proportion of the new and relapsed cases that were bacteriologically confirmed as well increasing. So this is just to tease out, in terms of our pulmonary cases notified, that there was a 20% increase. And this is really very good for the country, because overall, when we look at the performance for 2022, we noted that as a country, our notification cases went up. These are some of the benefits of rolling out new diagnostic tools, which really countries should be able to adopt. We did not just implement this process smoothly, and these are some of the challenges at the very early implementation phases that we noted. That there were issues to do with data capture because the registers were not being fully documented, and that the data was well available in the TrueNat system, and we were able to make memberships. Adherence to SOPs was a challenge, especially bringing out different types of errors, specifically error 5, that is an error that focuses on sample management. Other things to mention here is the indeterminate results management, where a test can give you an indeterminate results. And from the diagnostic algorithm I showed, it is well illustrated on basically what needs to be done, but that was not happening, but membership was done. Some of the lessons learned, my last slide, is implementation of the MWRD is feasible with a multi-stakeholder strategy, ensuring that all the roles and responsibilities of key stakeholders are well mapped. And the rollout of these new technologies, I think you have already seen that we have around 2,600 people who have tested positive, and we have been able to put them on treatment, meaning that there is improved access. For us to implement this process, and really we know health is devolved, then there was need to have a cadre that would support this particular process at county level. And the TrueNat super users came in handy, working closely with the county leadership to ensure that this is done. You've also seen 56 cases of drug resistance which have been identified. So really, in addition to the diagnostics strengths of the country, and that is very useful. Then when you look at the CQI system, the CQI tool that I talked about that we use to do membership with, I think that has also been very useful. And then the other part of it is the online data submissions that we really pushed to ensure data would come on a weekly basis to support us to ensure that we look at what is happening at county level and ensure that those gaps that are happening are well taken care of. As I wind up, just to appreciate key stakeholders who have been part and parcel of this process, and then wrap it there and say thank you so much. Apologies if I took more time. I think I was just enjoying the presentation. Thank you so much, and back to you.
Thank you very much, Kennedy, for that powerful presentation. Thank you very much. Now, real quick, in the interest of time, I would like to open the floor to anybody who might have a question or two to any of the three presenters. That is Dr. Walekwa, Sheila, and Kennedy. Questions? Maybe I could start, now that I have the mic. This goes to Dr. Walekwa. It's about the TQM, Total Quality Management. So is there a difference between TQM and any of the individual standards, for example, QMS? Because I saw you mentioned a few frameworks. And also, while on it, you could mention maybe the difference between continuous and continual improvement.
Thank you. Thank you, Dr. Walekwa, for your presentation. And it's an area that I also have some interest because of experience I've had. And when it's come to your inclusion criteria for the health facilities, in your opening statement, you say that looking at the lower facilities may be in tier 2. These are the health centers, the dispensaries. You look at that, their capability to produce quality results may be a bit low or compromised depending on their level of the facility. So my question is, in your inclusion criteria for the study, you are including facilities at what level? Okay, thank you.
Thank you very much. Do we have another question on the floor?
Okay, thank you. Thank you, Dr. Walewa, for the nice proposal. I have a few comments. I want to start on the problem statement. You indicated that there is no significant data to substantiate or to support why you are doing this study, but we are aware that we have some facilities in Nakuru County, like the likes of Aga Khan, which are ISO certified, the ISO 15189. Probably you can tell us, is it important to include some of those data, some of that data? Another issue is on your study area is basically Nakuru County, where we have faith-based, public institutions, and private. And in your methodology, I noticed you've captured sub-county facilities, relegating the issues of FBOs. Probably you can convince us why you left those out. Then on the issue of SPSS, you have a preference for version 25, and we have the latest. And I believe in research you should use the latest. Maybe you can convince us why you are biased on that. Thank you.
All right, good questions, those. We have another on the floor.
Thank you very much to the three presenters. My question also is to Dr. Walekwa. A very good study, especially now that we are looking at the quality management issues. I know a lot of cases of malaria that is always diagnosed, but you're not sure. So I was just wondering how you
Thank you, members, for the questions. It means you listened to me. I'll attempt to answer these questions. I hope I'll do it satisfactorily. Mr. Pius is asking whether TQM
would reconsider and use the SLIPTA checklist so that I remove the biasness aspect, because already there are labs that have implemented CQI. When you go to those labs, you will get information that can support your study, because I want to believe the reason why you are doing that study is to provide more information that can be used within the diagnostic space. Thank you.
Thank you, Ken. I agree with you fully about your view of how we should be able to evaluate the level of QMS implementation in our laboratories, actually by use of the sleep touch checklist. However, like I did indicate earlier, is that there is no information. Of course, I understand there is a number of laboratories that have already been evaluated using the sleep touch checklist. However, but that information is usually not made available, like for example, via publishing, so that we can be able to get an understanding of to what extent are our laboratories across the country implementing the QMS. So what we are doing now is, and it involves a lot, because the sleep touch checklist takes care of all the 8 elements of the TQM. What we are doing here, we have established a scope of the study, so that we can only focus on a few elements of the TQM to give a sneak peek of what exactly is happening in our laboratories. And of course, this underscores from where you sit, I believe, given the comment you've made, the need for intentional and deliberate and comprehensive evaluation of the extent of implementation of QMS in our various laboratories. So I agree with you. But for purposes of this study, this is a study that has a scope, and it will only give a sneak peek of to what extent our laboratories implementing the QMS. I hope you have heard me.
Thank you very much. Did we have any question for Kennedy or Sheila? Okay, I got one.
Thank you very much. Kennedy, I have one question about the TrueNut utilization, about clinicians. I know the gateway to the utilization of this equipment is mainly the sensitization and also the knowledge that the clinicians would have. So, what are the current? What is happening currently with the enhancing the knowledge with clinicians to enhance the utilization aspect? Thank you.
Yes. So before you answer that,
Thank you. So I also have a question for Ken. In one of the slides, he talked about reasons why it was not possible, although he said will, to mean future, why the UN TB targets, he said, will not be met. I believe he wanted to say were not met, because these were 2022 targets. And so with that background, I still want to go back to the QMS. These are UN TB targets. One of the provisions of the QMS is that you should be able to forecast possibilities of not being able to achieve and be able to map out the reasons. And of course, after you've mapped out the reasons, you attempt to mitigate those reasons. That's one of the provisions of the QMS. And these are UN TB targets. It's very scary that they were not achieved for the reasons that Ken highlighted. I think there was no reference, but I believe he has extracted them from somewhere. How sure are we going to be? I mean, have new targets been set? Because these were 2022 targets, and with those targets, are there mitigatory issues towards ensuring that the targets are achieved, and of course just minimizing the risks for not achieving them? Thank you.
Thank you very much. Kennedy, if you heard that, please respond.
Thank you so much, and I confirm that for sure you were listening to my presentation. So starting with the first question on the utilization. So a lot of strategies have been used to achieve this process and ensure that our clinicians, the clinical acumen, because remember, as I mentioned, that the first thing is active case finding. The clinician being empowered to know who is a true presumptive for TB and ensuring that those that are presumptive then are linked for diagnosis using the molecular diagnostic tools that we have.
Mr. Fred to continue the program. Karibu.
All right. Thank you, Professor. Good afternoon. My name is Frederick Otieno Oginga, and I am from the Department of Clinical Medicine. So I'll be a moderator for this session. Colleagues, and students, we have 3 more presenters who are going to present their Yes, hello, can you hear me? Yes.
Okay. Thank you. And
Salome? health aid. Good. You start that.
Yes.
Now let's start.
Um, yes, that's the back tertiary and in any country community health are primary health system, community health community but have as community health they promote health sanitation, they provide child practices, prevention of to the achievement of behavioral health coverage, the goals, the life are community health had part of the very from reduction of underrepresentation coverage. One this health work shortage. Community health workers are utilized to strengthen the declaration of the Alma on several examples of while extensive campaigns are running to see the eradication of like measles, leprosy, guinea, and it has also been demonstrated effectiveness in malaria prevention, immunization coverage, breastfeeding, CBDB management, and neonatal health compared to care where the community health program is utilized. Home in Ethiopia, I managed to see the reduction in disease burden by 39% between 2005 and 2020 by WHO because we have an extensive community health program. Kenyan context, CHVs, as the community health workers are locally known, has had an instrumental impact on improved health outcomes. A study done by itself in Kitui County noted that the infant immunization coverage went up by 10% due to implementation of the community health. However, as noted by the Ministry of Health in 2020 and documented in the Kenya Community Health Strategy 2020 to 2025, several challenges that have community health workers, this including inadequate numbers, capacity building forums, post-patient programs. This is emergency, like Ebola and COVID, the disease emergency also leads to reverse of gains that have previously been made through direct and indirect effects of the emergency. It's if the health system of a country is inadequately prepared. As seen by Baraza et al. 2020, who evaluated the indirect effects of COVID-19 pandemic in Kenya, it was highlighted that the pandemic led to disruption of supply chain, it led to shortage of commodities, volunteers new roles in addition to already existing roles, and those include public sensitization, case identification and surveillance, and contact tracing of relatives and community members, and facilitating referrals. CHVs were affected by the informality of their jobs, therefore they were never prioritized like the rest of the community of the health workers in accessing services that discussing the effect of COVID-19 emergency can the African operation the preparedness of COVID and high community facilities reports prepare this volunteer to handle the new duties in addition to the existing ones. There was inadequate preparedness, constant and familiar roles, travel restrictions, that affected how community health volunteers perform their routine community health services, which are required to go on with the government. So failure to assess and address the situations and the challenges that were encountered could lead to more indirect consequences in future pandemics. This study, therefore, aims to assess how CHVs perform their duties of these challenges. So there are three objectives. One was to evaluate the performance of during the COVID-19 pandemic in Nakuru County. Secondly, was to determine the COVID-19 pandemic preparedness of the community health volunteers for the continuation of routine community services in Nakuru County. Thirdly, was to determine the challenges to the effective performance of the community health workers, volunteers in service delivery during the COVID-19 pandemic in Nakuru County. The significance of the study: in previous outbreaks, few studies are done at the community level majority of the vulnerable population are served. Disruption of services can lead to increased mobility and rather than the one. Therefore, it's important to assess whether COVID-19 caused disruption of the community services and identify challenges that could have disruption. So this will assist developers at both national and levels. They can have opportunities for services of the community taken care of emergency. Performance have indicated that poor service delivery by the community health workers have been reported in previous system as reported by Celebity. Miller et al. In 2018 on the pandemic said that the initial stages of the pandemic led to decline in community maternal and child health services. So overall, health indicators declined in West Africa with the suspension of vaccination, outreaches, and reduced mobility. This led to indirect mortalities and preventable diseases with only 2% of these deaths from the other conditions. Emergency preparedness is essential to avoid disaster risk, reduce the magnitude of the effects of emergencies, and resilience of the system. So, framework for public health disease emergency preparedness is lacking. After the Ebola outbreak in West Africa, the United Nations and the World Health Organization advised that lessons from the outbreak should serve as a wake-up call to all nations to avert the health challenges in future emergencies. Developing for emergency principles and so community members of the community to be involved Brazil. The community health therefore that's a lot of fear as it is. The government released guidelines for community services, which directed each county guidelines. Health here, guidelines with low touch transmission. Literature review on health services outbreak in the country. Unfortunately, from the not reported to the community health volunteers. In 2020, the that there was no mental health structure to take care of the community. Was working in a structured COVID-19 in the county. Interviews were conducted, selected, where selected key informants interviewed. That is the community health unit chairpersons, community health officers in each sub-county, and sub-county community persons. Audio recording was done. The study population, total of CHVs in Nakuru County were 2,923. The target population of the CHVs in Nakuru East, Nakuru North, and Naivasha, that is 746. Therefore, the sample size was 260, which was using the Yamane 1967 formula for size calculation for Philippine population. Inclusion and exclusion criteria. CHVs who were in service at least 1 year before March 2020 were included. CHVs who had been registered at the sub-county and had undergone basic and technical training were included. CHVs who, despite offering COVID-19 response, were also involved in community health services. Those who excluded of community service, COVID was. I have some preliminary results of the questionnaires, still in raw data. These are the findings based on the important socio-demographic. 76% were male. So of the respondents, 99% had been in for more than 5 years by the time COVID was being recorded in Kenya, and 1% had been in service for 3 years, so they all met the basic criteria. 97 of the respondents, 98 of the respondents had undergone basic module training. 76 had undergone technical module training, and 86 of them had undergone both basic and technical module training. On to the performance. Most of the respondents, the CHVs, self-rated their performance before and after COVID-19, and most of them reported their performance as good, with a slight decline during the pandemic. There was a slight increase in those who self-reported their performance as having been very good with the pandemic. This table shows the services that were being offered, the ones that were being offered in the of round, the services that stopped with the COVID pandemic. So of those that stopped, and give promotion and of planning. Contributed. There was also a good number who stopped giving newborn services. That's with newborns to avoid spread of the infection. So the rest of the situation of the services that stopped with the pandemic included treatment of diarrhea, referral for newborn services, community postnatal care, referral for stillbirth deliveries, referral for antenatal care services, health education and promotion messages for normal conditions. They mostly focused on the health and education promotion messages for COVID-19. Then one of them stopped providing family planning services, and this family planning service is distribution. Was there a change in the number of cases served during the pandemic? Of the respondents say that there was an increase in the number of cases that we served during the pandemic. That was 60.7%. The reason cited was that since patients feared visiting hospitals, they would seek the services of the community health volunteers. They, during the pandemic, the increase in trust of the CHVs by the community members, so they sought the help of the CHVs. That was 9, and 4% of them was that they feared infection of COVID-19. Others say that most of the patients would prefer to self-treat at home. Preparation of the CHVs for service delivery during COVID-19. 58% of the CHVs said that they were involved in the county and their community officers, commonly known as HQs. 23% had a community unit in place on how the community health services will continue when COVID was recorded in their unit. 77% were trained on continuation of community health services. The rest, 23%, never received any training. 68% were trained on low-touch policy, and 74% advised to use community health high. Only 60% were involved in simulations and before they had cases reported in the unit. So 50% said that before COVID began, they did not have a supply. 3% were trained on communication, knew exactly how to do the to their colleagues and to their community. 66% had roles and responsibilities clear to them. The rest said there was a bit of confusion. 65% were informed on clear chain of authority, so they knew they would directly report to their chiefs, while others were a bit confused whether they should because they were required to get not an evaluation. However, 53% still felt that they were not prepared to continue. Was the community. Challenges any supervision. Yeah, 18.3% members who were seen as what were COVID and were seen one was 74 by community experience that on message community. Of the no psychosocial support. It's supposed to be according to guidelines weekly who also say training. Affected with experience had experience in described that she experienced social intervention. 75 years actually died. HIS that is being
Thank you. Presentation. And have the questions after two presenters. Kindly, members, I hope you've written your questions down somewhere. All right. So our next presenter, and we will have our next presenter be Luisa. Please, Luisa, can you hear me?
Yes, I can hear you.
We are presenting on terms of mutual presenters. Let's be time cautious. At least in 20. Luisa?
Yes.
Meanwhile, we can have also Jeremiah Okari. Just waiting. You are still time. Yes.
among children seems to be attending more than referral hospital in Kenya. Malnutrition is a public remains the most in the world. The most common non-communicable disease among children in the world. Percent. We have two countries, 25, Ethiopia and there was an area that was as 2%, central 1%, and western 1% found. Originally, a hospital was studied in Waranga County, uh, in cases coming from Kiambu in Waranga side, reported 2%. According to law 18, any preferences power intervention. Nutrition difference of among hospital is very high. The reported while 4%, and as expected, it clearly shows of effective prevention treatment. Therefore, it aims to assess the among children aged 6 in this referral. And the first and children established and access to nutritional rickets, and the third was the fourth is to do the relationship between the knowledge, attitudes, and beliefs, and this child and the incidence of nutrition. Research questions are related to status, for age, they use for age, which indicates that great on including rural nutritional rickets. And deal in preventing this condition. Housing conditions have been and the introduction of compound foods significant of conditions such as disorders they affect the nutrients this showed that homework. I looked at the independent variables, and of course the dependent variable. The variables, considering our first objective, which was the socio-demographic factors, looking at the age of the child, the gender of the child, the economic status of the child, of the family, the maternal education, and also parental occupation. The second objective is the dietary practices and patterns, looking at the type of the diet, e.g. breastfeeding, duration of exclusive breastfeeding. Also, it has an impact on nutritional rickets. Adequacy of dietary calcium and vitamin D intake, consumption of supplements or fortified foods, dietary diversity support. All these are the variables that are looking at the third objective clinical signs, symptoms, assessment, the growth charts, all this will be considered under this objective. There are also confounding variables like sun exposure, how much time do they spend outside with the child, where are they coming from, which kind of housing do they live, is the house able to access to sunlight, or it is house which is somewhere where there is no sunlight or sunlight cannot be able to reach there. Maternal knowledge about rickets or prevention or management, and even the presence of underlying medical conditions like chronic kidney disease and liver diseases or malabsorption diseases, which affect this the metabolism of those nutrients that are needed for nutritional ricket alleviation. So this can directly, indirectly impact the dependent variable, the outcome of the dependent variable, which is the incidence of nutritional rickets. The methodology is that this study will employ cross-sectional study. It will take place in Moranga County Referral Hospital. It will target the children 6 to 59 and their mothers or the caregivers, those who seek the care in this referral hospital. The positive sampling method shall be used to select children who have been diagnosed with nutritional rickets. And structured questionnaires will be used to collect data on socio-demographic factors, dietary patterns and practices, and nutritional status. With discussion guide will be used to collect on maternal knowledge, attitude, and practices towards child nutrition. My inclusion criteria is that the children aged 6 to 59 months attending this Moranga Referral Hospital, children with laboratory confirmed diagnosis of nutritional rickets, and children with parental or guardian assent to participate in this research will be included. And those caregivers meeting the inclusion criteria but who might not want their children to participate will be excluded. Some sites was using Cochrane formula, and this is how I arrived at a sample of 120 children with rickets. My data collection instrument shall be given to the supervisor in the nutrition department and also in the senior officer in the occupational therapy department for review, and any review, anything that comes out will be revised. I also plan to do a pilot study, 10% of the sample size at the Marawa level, which has a pediatric clinic also, to determine the data collection tools and then shortcomings of experience be observed of the actual study. I will use test retest reliability. I will give a set of participants with questionnaires in 2 separate periods to ensure their questionnaire reliability, and this will be calculated using Pearson correlation, and any correlation that will show a high correlation that will be considered reliable. My analysis, considering the objective and the variables, like the first objective, to consider the variables, I will analyze it using the descriptive statistics. Will be analyzed using survey, and that will be analyzed for SMART community survey, and also the fourth objective will be analyzed using the chi-square, the Pearson correlation, the logistical regression, and the odd ratio. And this is the end of my presentation.
Thank you so much, Luisa, for your good presentation. Dear members, please appreciate we'll have a presentation presenting virtually. Please make sure that you take consideration of the time. So we have Jeremiah Okari. Jeremiah, confirm that you can hear me. Or Frida Kiptui. Please confirm that you can hear me. Frida Kiptui. Or Jeremiah Okari. Please could you check if those members are available among the participants who are online? If not, we take questions from the presenters who have presented already. In the interest of time, I will go ahead and take questions from the presenters who have had their presentation. This should be my last call. Jeremiah Okari, if you can hear me, please respond. Or Frida Kiptui. All right. So in the interest of time, we are going to take questions from for the presenters who have already had their work presented. I don't know if there are members who have questions, or I can go first, because I have some questions here for our first presenter. I don't remember her name. I think it was Salome Gashati. More questions, perhaps, if there are any. Thank you. Salome, you can go first, and then we can have Orina going after you, kindly.
Okay. So I'll respond to my three questions. First is my recommendation on how to strengthen the role of CHPs. So my first recommendation is to have these CHVs given airtime to be able to conduct their work as community health volunteers, because with the emergency of the pandemic, their role has been found to be very crucial, because they help the health workers get as low as to the level of the community. So they need to be given airtime for them to be able to contact their clients and to communicate back to their supervisors. They also need to be given some sort of transport. They're supposed to cover a region within which they live, but sometimes some have reported that that is quite tiring. So any form of transport that would be given to them would be very appreciated. They also need to, another recommendation is to have the training, the training on emergency preparedness and community and response at least every 6 months, maybe twice a year, so that they are prepared before a pandemic is reported in a country. They don't have to wait for a pandemic to be reported. They need these preparations done so that they are all when the pandemic happens. That will reduce the fear and will increase their confidence when a pandemic happens. So those are some of the recommendations I can give for now. In terms of use of triangulation methods, I would say currently I'm still doing my data analysis, and I will see whether that will be applicable in my study. So far, I have not applied that. In terms of CHVs not being on salary as of now, as a maybe say as a government policy, yes, the CHVs are not on any form of salary, but after the pandemic, those in Nakuru County are regularly receiving a stipend. However, during the pandemic, only 60% got some sort of motivation from the county, which was described as an amount of 2,000 shillings that would happen sporadically. Some will take 3 months and some 6 months, but some 60% of them got, while 40% did not receive any. And they recommend that if motivation is given to one, then it should be given to all to motivate everyone to work. So that was the kind of motivation that they received, and they look forward to being enrolled by the new government in the as a health promoter, so that they can be able to get their monthly stipend more regularly. Thank you.
Thank you so much, Gashati. I think we can now list. You can.
Below 5 years, so that if we get these cases, they can be benefit from that. And also supplementation can be done to the pregnant women, because this also there's a study that I saw that children who are exclusively breastfeeding, they benefit from their breast milk, the breast milk of the mother, if the mother had adequate stores of vitamin D. So this recommendation can be able to save these cases that are getting the nutritional rickets while they are breastfeeding. And also another recommendation is about food fortification. If food can be fortified with these kinds of nutrients, the vitamin D especially, and calcium, it can be able to help in reducing these cases, so that that generation is also benefiting from that. Another recommendation is about public health campaigns, where we can be able to give people education on how to identify the early signs, the clinical signs of nutritional rickets, how they can be able to come up with a diet that is able to fit into these children, so that they may be able to know how to combine different food groups from different classes. Another recommendation can be also early diagnosis. This is in the clinical setup. If they can be able to detect it early before the complications occur, because there are so many complications that arise if this nutritional ricket is not dealt with. One of it, it's like mental, there is motor delay. You get that the child does not proceed well in terms of milestones. Get a child is 1 year but cannot be able to walk or stand. So those ones can be able to be minimized if early diagnosis is done. So those are some of the recommendations that I can be able to give to the policymakers, so that they can be able to incorporate them and make sure that they have been implemented. To the second question about the variables, variables are the ones that I found have a relationship with these nutritional rickets, and that's why I developed this conceptual framework. Yeah, I hope I've answered the question.